All right, welcome to the afternoon session of the 2024 SIPP Virtual Conference. I'm Bryce Vanderberg. I'm an economist in the Labor Force Statistics branch here at Census, and I'll be your chair for the session. Just a few housekeeping things to get started. As with prior sessions, each presenter will have approximately 30 minutes, and after all three presenters have had a chance to present, we'll open it up for some Q&A. You can put your questions in the Q&A section on the screen, and myself and you others will moderate or will monitor that to make sure that we get your questions asked once we get to the Q&A session. Okay, so our first presenters today are Rakesh Kochhar and Mohammed Mazlimani from the Pew Research Center. So Rakesh is a senior researcher at Pew Research Center. He is an expert on trends in employment, income, and wealth. His research has focused on the American and global middle classes and the economic well-being of white, Black, Hispanic, Asian, and immigrant workers. Prior to joining Pew Research Center, he was a senior economist at Joel Popkin & Company, where he served as a consultant to government agencies, private firms, international agencies, and labor unions. Kochhar received his doctorate in economics from Brown University, and he has appeared on numerous media outlets, including NPR, CNN, MSNBC, and Fox News. He has testified before Congress and regularly speaks at professional, academic, and business conferences. Mohammed Mazlimani is a research assistant at Pew Research Center on the race and ethnicity team. On the team's survey research side, Mohammed contributes to survey design, publication management, number and fact checks, and original analysis. On the secondary data side, Mohammed maintains many of the team's demographic and economic statistical portraits, which explore differences within racial and ethnic groups and across immigrant generations. Mohammed graduated from Claremont McKenna College as a philosophy, politics, and economics major, and has worked on the race and ethnicity team ever since. So take it away, guys. I will let you know when we get to 10 minutes remaining, and I'll give an additional reminder at 5 and 1 minute if we need to.
As I was saying, Mohammed and I are with the Pew Research Center, a subsidiary of the Pew Charitable Trusts. The center is a non-profit fact tank that informs the public about the issues, attitudes, and trends shaping the world. It is non-partisan and non-advocacy, meaning that the center does not take policy positions or make recommendations. I guess that is something we share with the Census Bureau. I'm here to discuss a recent report on the wealth of US households and how it changed during the COVID-19 pandemic. While I will be the sole presenter, Mohammed is here to address questions as well. So a brief outline of the presentation first. I will begin by describing trends in the wealth of US households. Overall, over the period from December 2019 to December 21. These estimates come from SIPP surveys conducted in 2020 and 2022. It should be noted that the estimates for December 2019 may be affected by the impact of the pandemic on data collection efforts by the government in 2020 and 21 as well. After the look at overall trends, I will focus on how the major racial and ethnic groups in the US fared financially, along with outcomes for households at the opposite ends of the wealth spectrum. Finally, I will offer a brief comparison of wealth estimates from SIPP and the Survey of Consumer Finances, along with a very quick take on our experiences working with SIPP data. Now, just to be clear on the terminology, wealth or net worth is the difference between the value of assets owned by a household and the level of debt held by that household. Unless otherwise mentioned, estimates of wealth that I will mention in this presentation refer to median values. Also, the dollar amounts are expressed in December 21 prices. The exception is when I compare SIPP with the SCF, at which point dollar amounts appear in 2022 dollars. So looking at the wealth of US households overall, American families made strong financial gains during the pandemic. In the first year of the pandemic, median household wealth increased from about $128,000 to about $151,000. This was a real gain of 17.5%. In the second year of the pandemic, median household wealth increased from $151,000 to $167,000, an increase of 10.7%. Overall, in the first 2 years of the pandemic, US household wealth shot up by about 30%. So the obvious question one might ask is, why did wealth increase so sharply during the early years of the pandemic? Well, it turns out several macroeconomic trends favored households during this period despite the recession in 2020. One factor is the policy response to the recession. Because of tax credits and other transfers, the after-tax income of US households actually increased in real terms by 3.5% in these 2 years, even as gross pre-tax income was falling. Moreover, these payments were targeted towards lower and middle-income families who typically have less wealth. The pandemic itself helped boost household savings initially by driving a reduction in consumption. Research shows that US households had saved about $2.3 trillion more during 2020 and the first half of 21 than they might have saved at pre-pandemic trends. That is upwards of $15,000 for each household on average. Finally, home prices kept climbing, stock prices kept climbing, and mortgage rates came down in these first 2 years, all beneficial to the finances of households. Now, the gains in wealth during the pandemic were well distributed across US households, perhaps more so than we have seen in recent US economic history. One sign of this is that the share of households in the middle tier of wealth increased from 41 to 44% from 2019 to 2021. At the same time, the shares of households in the lower and upper tiers of wealth edged down by about 2 percentage points each. So wealth equality increased or improved during the first 2 years of the pandemic. Even so, there are wide disparities in wealth within each wealth tier. When I talk about the middle tier of wealth, I'm talking about households with wealth anywhere from 1/4 to 4 times the median US wealth. In 21, this ranged from anywhere from $42,000 to $668,000. So that is a pretty wide tier of wealth. In another sign of improving wealth equity, the net worth of lower and middle income households increased at a faster rate than the wealth of upper income households. The median wealth of lower income households doubled during the first 2 years of the pandemic, from about $12,000 to close to $25,000. These are households whose income is less than 2/3 the national median household income, after incomes have been adjusted for household size. Upper income households, those with income more than double the national median income, saw their wealth increase by 15% to about $800,000. The median wealth of middle-income households increased by 29%. Of course, a notable caveat is that even small percentage changes in net worth at the top lead to large absolute gains. So the absolute difference in wealth between upper income and other households did increase in the pandemic. Now, as you might have surmised from the macroeconomic trends I noted earlier, the increase in household net worth was driven by increases in the values of key assets. Based on ownership rates and asset values, the two most important assets for the typical US household are home equity and retirement accounts. Most importantly, the median value of home equity increased from $141,000 in 2019 to $174,000 in 2021, an increase of 23%. Holdings in retirement accounts increased from $71,000 to $76,000. The values of other assets either held steady or increased slightly. This stands in great contrast with the Great Recession, when asset values had tended to fall sharply. The importance of home equity to US household wealth is also underscored by a look at the median wealth of all US households with or without home equity. With home equity included, median wealth is about $167,000. Without home equity included, median wealth is only about $58,000, a difference of close to $100,000. Among homeowners alone, home equity accounted for a median of 45% of their net worth in 2021. Now, on the other side of the ledger, the level of total debt held by US households was largely unchanged during the pandemic, hovering between $20,000 to $25,000 in these two-year time period. There was no change in either the level of secured debt or the level of unsecured debt. So with rising asset values and debt holding steady, US households became more financially solvent during the pandemic. As measured by the debt to assets ratio, that fell from 35% in 2019 to 30% in 2021 at the median. And there was no change in the debt to income ratio. So at least from the point of view of wealth, US households overall emerged in better shape than before the pandemic started. Of course, this is a story that is still being written, and we don't know what the next year or two hold. So now let me turn to the wealth of individual racial and ethnic groups. Reflecting the theme of widespread gains, all major racial and ethnic groups in the US saw strong gains in wealth from 2019 to 2021. Black households nearly doubled their median wealth from $15,000 in 2019 to $27,000 in 21. The wealth of Hispanic households increased by 42%, and that of Asian and white households increased by 43% and 23%, respectively. But as it has long been the case, Black and Hispanic households have much less wealth than white and Asian households. Asian households currently lead the pack with a median wealth of about $321,000. The increase in wealth for each racial and ethnic group was also driven by gains in home equity. For example, the median level of home equity among Black homeowners increased from $90,000 to $113,000, or by about 25% in this two-year period. Otherwise, the increase in home equity ranged from about 20% for white homeowners to about 36% for Asian homeowners, consistent with the economy-wide gain in home prices. Home equity is especially important to the net worth of Black and Hispanic homeowners, the majority of whom derive about 60% or more of their wealth from home equity. White and Asian homeowners, on the other hand, derive only about 40 to 45% of their net worth from home equity at the median. Now, turning to the financial solvency of households during the pandemic of different racial and ethnic groups, Black and Hispanic households also saw notable improvements in financial solvency during the pandemic, as measured by the debt to assets ratio. The median debt to assets ratio for Black households fell from 53% to 40% in just this two-year period. The ratio for Hispanic households dropped from 44% to 36% over this period. Nonetheless, they are more indebted than Asian and white households, who, by the way, do carry larger absolute amounts of wealth, but because larger absolute amount of debt, but because they also have so much more wealth, their debt to asset ratios are lower. There's another way to look at how wealth compares across racial and ethnic groups, and that's simply to look at the share who have no wealth or are in debt, that is, have negative net worth. Overall, about 1 in 10 US households, 11% in 21, had either no wealth or were in debt. This was an improvement over 2019 when 15% were in this situation. Black households are the most likely to be in this situation. About a quarter of them had either no wealth or were in debt in 21, although this was down from 29% in 2019. The shares of Hispanic households and multiracial households are roughly about 15% are in this position, and white and Asian households are the least likely to have either no wealth or be in debt. From the estimates I have reported so far, and this is not news, there are large gaps in wealth across America's racial and ethnic groups. In 21, the typical white household had 9.2 times as much wealth as the typical black households. This ratio stood at 13.3 in 2019, prior to the onset of the pandemic. White households also have significantly more wealth than Hispanic households, a ratio of about 5, and they have about 3 times as much wealth as multiracial households. But the median wealth of white households is about 20% less than that of Asian households. The wealth gaps between white households and Black and Hispanic households are in line with recent history. But the apparent shrinking of racial and ethnic wealth gaps during the pandemic stands in contrast with what happened during the Great Recession. In that recession, the median wealth of white households had jumped to nearly 20 times that of Black households and 15 times that of Hispanic households. The key factors then were a sharp decline in home prices and a steep rise in home foreclosures. Black and Hispanic households saw more harm from these developments, as housing is a more valuable part of their collection of assets. But these events were absent during the pandemic. Now, the wealth gap across racial and ethnic groups cannot be explained away simply by differences in income across these groups. Indeed, large gaps in wealth persist across groups, even among those with similar levels of income. Most notably, the median wealth of lower-income white households was about 21 times the median wealth of lower-income Black households. This was not much different from 2019 either. And in the lower income tier, white households have about 5 times as much wealth as Hispanic households in 21. Sizable gaps in wealth persist across racial and ethnic groups, even in higher income tiers. In the middle income tier, for example, white households have about 3 times as much wealth as Black households. And in the upper income tier also, white households have about 3 times as much wealth as Black households. Of course, it is also the case that Black and Hispanic households are much more likely to be either lower income or middle income compared with Asian and Black households. So this distribution by income compounds differences in racial and ethnic wealth gaps. Now, going back to the distribution of households by wealth tiers, as noted earlier, increases in household wealth during the pandemic did lead to a more equal distribution of wealth among US households overall, with more of them climbing into the middle income tier. And the same can be said for Hispanic and white households, whose shares in the middle tier of wealth increased by 3 to 4 percentage points from 2019 to 2021. However, no such change was experienced by Asian households, with their share in the middle wealth tier holding at 39%. The observed increase in the share of Black households in the middle wealth tier from 35 to 38% proved not to be statistically significant. Now, at the top end of the scale, what we see is that only 45% of Black households are in either the middle or upper wealth tiers, the lowest share among the groups examined. In contrast, more than 70% of white and Asian households are in either the middle or upper wealth tier in the United States. So finally, the last major section of our report, in addition to looking at how gains in wealth were spread across racial and ethnic groups, we were also interested in the question of how deep these gains were within each group. So for this purpose, we divided households into wealth quartiles. We labeled the 4 quartiles as poorer, more solvent, wealthier, and richer. The bottom 1% and the top 1% are excluded prior to the ranking, so extreme values do not affect estimates for poorer and richer households. Also, these groupings are made independently for households overall and for households within each racial and ethnic group. This means, for example, that richer Black households are not necessarily in the same bracket as richer Hispanic households, and so on. Now, the rising tide of wealth during the pandemic did lift all boats, but some are more afloat than others. Poorer US households were likely to be in debt both before and after the pandemic. In December 2021, half of these households had a net worth of $500 or less, a modest gain from December 29 when half had a net worth of $0 or less. Technically speaking, the increase in median wealth for poorer households from 0 to 500 is infinitely large, but it is not as meaningful as the gains experienced by households with more wealth. More solvent households gained about $20,000, wealthier households gained close to $60,000, and richer households added about $170,000 to their net worth at the median. One group that remained in debt before the pandemic and after the pandemic were poorer Black households. That remained the norm among them. Their financial situation did improve. They were debt to the tune of $10,000 before the pandemic at the median, and in debt to the tune of $4,000 after the pandemic, or 2 years into the pandemic. An improvement, but nonetheless still in debt. Poorer Hispanic households too remain on the edge of debt, with a median net worth of $0 in December 2021. Poorer white and Asian households appear to have landed on much firmer ground during the pandemic, reaching a median net worth of about $5,000 and $9,000 respectively by 2021. Looking nearer the top at richer households, the level of wealth does vary greatly still across white and Asian households on the one hand and richer Black and Hispanic households on the other hand. Richer Black and Hispanic households had a median net worth of about $400,000 to $500,000 in 2021. This was still just a fraction of the median net worth of richer white and Asian households, who had 1.5 million and 1.8 million respectively. So even though richer Black and Hispanic households have, comparatively speaking, modest amounts of wealth, wealth inequality is at its highest within Black and Hispanic households. So this slide shows the ratio of the median wealth of richer households in a group to the median wealth of more solvent households in that very same group. We don't use the wealth of poorer households in the denominator because among Black and Hispanic households, it's either 0 or negative. Among Black households, richer households had 62 times as much wealth as more solvent households in 21. This was a significant decrease from a ratio of 136 in 2019. Likewise, the ratio of the wealth of richer to more solvent households among Hispanics decreased from 45 to 28 from 2019 to 2021. The ratio is much smaller among white and Asian households, between around 10 to 20, and it did edge down also during the first 2 years. So considering the large disparities in wealth within all racial and ethnic groups, it is not surprising that richer households in each group hold most of the total wealth among a group, but their share did inch downward during the pandemic. So among all US households, the richer 25% of households held 82% of the wealth in 2021. This was slightly down from 2019 when their share stood at 84%. Large by any standard, but still nudged down a bit. Uneven wealth distribution is more pronounced among Black and Hispanic households. Within these two groups, the richer 25% of households held 90% and 85% of total wealth in 21, respectively. These shares were somewhat less among white and Asian households. One important caveat to note here is that we have excluded the poorest 1% and the richest 1% from our analysis. So this means that the concentration of wealth that I'm showing here is likely very much understated. But the key part is that the change is in the direction of slightly more equal distribution. So now let me turn to a brief comparison.
About 5 minutes, Rakesh.
Yeah. So let me turn to a brief comparison of our results at the top level with those from the Survey of Consumer Finances. The SCF came out even as we were writing our report using SIPP data. To us, SIPP retains an edge from up because it offers a much larger sample size, allowing for more in-depth analysis of outcomes for racial and ethnic groups or poorer and richer households. Still, we thought it would be of interest to compare some top-level estimates from SIPP and the SCF. Now, one thing to keep in mind when comparing the two is that the SCF data were collected over 2022 and the first half of 2023. The latest SIPP estimates refer to December 21. Thus, we can expect that the estimates from the SCF will be a bit higher. With that in mind, the estimates for US households overall and for white households are similar across the two surveys, within 10% of each other. But the SCF estimates for Black and Asian households are about 55% higher, and those for Hispanic households are about 20% higher. So it does appear that the SCF and SIPP may be capturing different segments of these populations. The SCF also shows less extreme gaps in wealth across white and Black households. The white to Black ratio of median wealth was either 9.2 according to SIPP or 6.4 according to the SCF. Here too, it is worth noting that the SCF has historically shown smaller gaps in wealth across racial and ethnic groups than SIPP. So let me conclude with a very quick take on our experiences with SIPP. This is the first time I turned to using SIPP in a little over 20 years. Much has changed in SIPP itself over that time. A very different survey than what it was back in the 90s and the early part of this century. But using SIPP for the first time user can be a bit daunting. It has a steeper learning curve than, say, the CPS or the ACS. And it lacks the advantage, I guess, of being featured on IPMs. The online codebook can be frustrating at times if just the right search term is not used. But, we were able to make our way through everything, consulting either the online handbook, online codebook, or the printed codebook. Given our research interests, the one thing or one small request we have is we would welcome the addition of a variable on the respondent's country or region of birth, because we are interested very much in how immigrants from different parts of the world do fare in the United States, financially and otherwise. But the SIPP staff were extremely helpful in addressing all our questions, which was very, very valuable. So I would express my great thanks to the staff for helping us out. So that is all I have. If you want to look at the report in detail, it's available on our website at Pew Research. And you can also contact me. There's my email. And thank you very much. That's all I have.
Thank you, Rakesh. That was very interesting. And just a reminder, if you have questions, feel free to put them in the Q&A and we'll get to them after the remaining presentations. So up next, we've got Hector Ortiz from the Consumer Financial Protection Bureau. He is a senior policy analyst there, where he works on initiatives related to debt in older ages, financial literacy, retirement security, and elder financial exploitation. Hector has provided technical advice to the U.S. Senate Special Committee on Aging on these issues, and previously he worked at the National Council on Aging. Take it away, Hector.
Thank you, Bryce, and thank you, everyone. I will be sharing my slides here. Okay, you should be seeing now my slides. Good afternoon, everyone. My name is, again, Hector Ortiz. I am with the Office for Older Americans at the Consumer Financial Protection Bureau. And I want to thank the Census Bureau for inviting us, reaching out, and providing this opportunity to share our work with you. My presentation today focuses on the issue of medical billing and debt collection among older adults. I also want to thank the Census Bureau for making the SIPP available publicly with all of the resources for people like me to be able to mine the data and support our work. So a little bit about the CFPB. We are a federal agency. We were created in 2008, and we have been 2010 after the 2008 mortgage crisis, and we're dedicated to protecting consumers from unfair, deceptive, and abusive financial practices. We have enforcement, supervision, regulation, research, and market functions. And we also are responsible for consumer education. We ensure that there's fairness in the markets for consumer financial products and services, whether it's a mortgage, credit card, your credit reports. And one of the areas that we have been doing a lot of work recently is in the area of medical debt. And one of the things that we're doing in this space is we're ensuring that unpaid bills are reported accurately to collectors and credit bureaus, and that people are treated fairly when dealing with collectors and credit reporting agencies. As any other Fed, I have to disclaim that even though I'm presenting on behalf of our agency, any comments that I make today here do not constitute legal advice, but also that may not represent the views of the agency. Today, I'm going to cover some background of the project where we use the SIPP, our methodology and specific use of the SIPP data, as well as our findings related to the prevalence of unpaid bills among older adults. So many of the issues that relate to medical debt come to the attention of our agency when people are struggling with a debt collector, or when they see an unpaid medical bill reported in their credit reports. And those typically come to our agency in the form of complaints. We have been doing quite a lot of work in this space. In fact, in 2014, we published a report, and one of the findings of that report that was using credit bureau data was that half of the collection trade lines in people's report were medical collection trade lines, and that those were not the result of loans that people have for medical purposes, but they were related to unpaid medical bills. And that a large portion of consumers with medical collections had no other evidence of financial distress, in that they were ordinarily paying other financial obligations in time. In other words, like that the presence of these medical collections were not predictive of future delinquency on payments, which is what a credit score and a credit report is intended to do. So this led to a lot of our work in that space that continues today, and in fact, currently there's rulemaking or a rulemaking process that that will consider alternatives that among them could remove medical bills from consumer credit reports and stop creditors from relying on medical bills for underwriting decisions, but also will deal with coercive collection practices. From our offices for older Americans specifically, one area of interest is helping consumers understand their rights when they're facing a debt collection for an unpaid medical bill, including when those efforts are for bills that they don't owe. Our particular interest in unpaid bills in billing accuracy results from the fact that there's a lot of research and evidence out there around the accuracy and the of these reports, and there's some evidence that there's a lot of billing records, billing errors in the process. And those could range from 7% of bills, depending on the study, on the specific sort of type of biller that is being studied, Medicare or Medicaid, ranging from 7 to 40, all the way to 49%. And the American Medical Association, for instance, came up with the 7% estimate, but other studies have found much higher rates. In several companies that do precisely work on revenue management are stating that a lot of the claims that are denied for any record, about 60% of them are never resubmitted, and in the end, the consumers end up paying for bills that probably they don't owe. And in 2022, in fact, Kaiser conducted a survey on this set of issues, and what they found was that 44% of adults with unpaid medical bills they did not pay the medical bill in full or only partially because they were not sure about the accuracy of that bill. So why it's inaccurate billing in particular of interest to the CFPB is that the in the Office for Older Americans, and that is that a lot of the people who typically in older ages, the older consumers that we're focused on, as well as people with disabilities, they have multiple chronic conditions. That means that they require the more complex type of billing codes that are usually rejected by health insurance plans because they are largely scrutinized, and there have been evidence of sort of abuse of those. And so those are likely to be rejected again and not resubmitted. Secondly, they are also dealing with multiple insurance. So the older segment of the population usually will have Medicare with some other form of insurance, supplement or VA or Medicaid. And so once you have two insurers, you have two insurers that you have to bill for reimbursement, complicating again the process. And then the last has to deal with challenge of the population itself around limitations for being able to detect and correct the billing errors. So this for us, it was very important to understand the prevalence of unpaid bills among older adults, specifically, and look at how it aligned with those groups that are at high risk of inaccurate billing based on those results, and just understanding broadly the prevalence for those who are uninsured and against the younger population. And the SIPP provided the best data for that. And in fact, what we did was we relied primarily on analysis of the public, the public version of the SIPP for 2020 and 2021. The sample size was significantly limited for each year once you look at this relatively rare sort of experience, but particularly in the older segment. And all of this was just cross-sectional and descriptive. We certainly apply the weights, and we primarily focus on two variables: did you have any medical bills that you were unable to pay, and how much did you owe for medical bills, and all of this was done at the individual, so we were not aggregating the household presence for the individual reporting medical debt. And one of the things is that the SIPP does sort of prompts a response by providing detailed specifically about what kinds of bills to include. And again, this is very helpful in terms of understanding again the limitations of the survey data, which as we and the strengths again. And so what we know from this is that that it has several strengths compared to other sources that we looked at. One, it has the prevalence, but also has the amounts. It allows both for look at the household versus the individual, and it also has a very rich set of household and individual variables, from insurance coverage to demographics, and also other variables that are good to contextualize, including healthcare utilization and out-of-pocket expenses. It was also helpful because we were able to compare to pre-pandemic, and we were also able to again look at the younger segment and the uninsured, and relatively, good sample for in other surveys we were looking at fewer than 200 respondents, and in this at least we have 900 to at least compare within the group. And in some cases we also leveraged the panel design too to look at some of the people who had debt in 2020 also reported debt in 2019. But we also know that aside from the biases that are typical in surveys like this, there are two important, there are a couple of limitations that we have learned from both, from comparing to other sources and the wording in other sources for this question of medical debt, but also we took your question and we actually did some cognitive testing on it with consumers. And one of the things that we learned is that often people, if they had put those medical bills in a credit card that's still unpaid, they didn't treat it anymore as an unpaid bill. Like for them, the bill was paid now. It's just that it's now credit card debt. We also learned that certain bills in disputes were not included here. But we also struggle a little bit with both trying to look more carefully at the type of Medicare, Medicaid dual status, and the Medicare Advantage participation in particular, which was important to us because that's an area that has changed a lot in terms of coverage for older adults. It seemed to be relatively undercounted, that specific type of coverage in the SIPP. So with those in mind, I would want to share with you some of the key findings of our analysis. And one was that what we found was that a growing number of older adults were reporting having unpaid medical bills. And this is particularly concerning in light that many of them have pretty comprehensive medical insurance. What we found is that in 2020, 7% of adults had unpaid bills, and that's lower than the younger population, which only had 11%. That had 11% of adults had unpaid bills. Those again between the ages of 18 to 64. We found that again the similar percentage had unpaid bills in 2020 as in 19, but the number itself, the estimate for the number was slightly higher. In other sources, we found a similar pattern in the data, including the CHED and the Medicare current beneficiary survey too, which have similar questions. The reported amount was what was more concerning to us, that we noticed a significant increase between 2019 and 2020 And it was concerning given that a lot of people reported fewer doctor visits and lower out-of-pocket expenses than in 2019. We were also surprised by that, given that Medicare spending in general was much lower than the rate of growth in unpaid bills. And this again is all possible because of the rich set of variables that is available in the SIPP around utilization and out-of-pocket expenses. We also found that the vast majority of this unpaid bills are held by people with insurance, and we're looking now at the Medicare population, so coverage is pretty universal. So Medicare does play a big role in both seeing that lower rate among older adults, but also the fact that the vast majority of the people are that have unpaid bills are in fact covered at least by Medicare. But what's surprising is again that 70% of those who were covered, who have unpaid medical bills, are people with two or more sources of insurance, and that's usually people with Medicare, Medicaid, people with Medicare and Medigap, Medicare and TRICARE. Again, things that are intended to serve as wraparound. And in some cases, like Medicaid, there's a significant protection against any type of balance billing and any additional sort of costs and protection against those additional costs. We also observed, again, the patterns all make sense, that the uninsured older adults had the highest level, that 2%, that 1% of the population that had no insurance had the highest rate. And anyone who had like just one insurance that was not Medicare only also had a pretty high rates. So usually these were people who only had one insurance, probably not qualified for Medicare yet. And then there were those who had Medicare only, and these are usually what we would call the underinsured Medicare beneficiaries that have no other form of coverage. And you systematically can see the order here, that the sort of those who have Medigap and some form of Medicare plus employer sponsor had the lowest rates. But again, just want to draw the attention that the Medicare Advantage was somewhat of an undercount, as some of those we believe may have been counted under employer sponsored coverage. But to us, what was particularly surprising here was the high rate among those who are in the Medicare and Medicaid population. This is a population that it's supported by two of the key government programs, has gotten a lot of attention from a wide range of groups, and this group of dually eligibles reported not only a pretty high prevalence of bills, but also a high amount. And the interest in this population is because one is a pretty big group. We're looking at over 7 million adults that are in this sort of category of getting some form of full Medicare and Medicaid protection, and that there is a set of protections for this group, particularly one category that is called the qualified Medicare beneficiaries have a significant protections against being balance billed, and the program covers their cost sharing, and there's a set of protections against being balance billed. And people who have those protections, again, should not have out-of-pocket expenses, and protections are vital because these are usually the population that have the most healthcare needs, as well as they have the lowest income and assets, and that is why Medicaid is sort of paying for the cost of Medicare. They also cover things that Medicare doesn't cover, like dental, hearing, vision care. And again, this category of qualified Medicare beneficiaries is the largest category of this dually eligible individuals, and yet again we see this high rate of unpaid bills. We tried to understand a little bit more of this, and right now we're working with actual Medicare current beneficiary survey, and those patterns that we're observing here, replicating their data too. And what was interesting to us was that that with the data available in the SIPP, we were able to also look at whether or not some of this may have been the result of churning or the result of prior debt being held. And so the longitudinal design was leveraged to look at this sort of just basic questions of which are not that basic, but very important in this case. To what extent these two factors could explain the high rate of unpaid bills among dually eligible. And what we found was the 66% of dually eligible older adults with unpaid bills in 2020 did not have any unpaid bills in 2019, and that the vast majority of them maintained consistent Medicare, Medicaid coverage through 2020. We look at this, and our Office for Older Americans have a sort of somewhat of a big consumer protection focus and looking on behalf of the consumer, and to us was important also to tell a story about this. So we, as I say, a lot of these problems come to our attention through complaints that people file with our agency. We have received hundreds of thousands of those, and in this we see an alignment between the SIPP data and our complaints, in that the vast majority of the unpaid medical bill complaints are coming from people with comprehensive insurance coverage, and there is a lot in those complaints that relate to issues related to inaccurate billing. Between March of 2020 and 21, we received about 1,000 complaints on debt collection from consumers who had Medicare, and a lot of this, again, were complaining that the debt that they were being collected on was inaccurate. You can see here that compared to all the Medicare benefit complaints that we received, those that were submitted by those who were citing in their complaints 2 or more sources of insurance were the ones that were more likely to say that the collector was going for debts that they didn't owe. And one keyword in all those complaints is, I have QIMB status and they should not be balance billing me for X, and I have never paid a single dollar on this, but now they are charging me for this procedure. These issues, we also read in this complaint some of the challenges that people face trying to correct the problems, and those include the what we call the doom loop of trying to correct the bill from the debt collector saying, I don't have the paperwork, you need to contract your provider. And so we know that there is a billing system that is devoting very limited resources to help people in correcting those errors and navigate the system. And in this very complicated thing, the complaints provide some of that consumers' own voice around some of the challenges that they have, how it is affecting their health, the amount of time they're spending there, and particularly once debts are sold and transferred to different collectors. But one way that the SIPP helps us understand is we can look at those who pay medical bills, and we can look at their factually their financial situation and their their risk factors, and one of the ways that the SIPP allows us to contextualize is that we're able to look at some of the challenges that we hear in those complaints are navigating this process difficult. Those include hearing, mobility issues, vision limitations that are captured in the disability questions. And consistently what we find is, again, those who have older adults who have unpaid bills are, by virtue of needing care, but also by virtue of their own needs, they have all of these challenges that at the same time make it very difficult for them to navigate their bills and correct those erroneous bills. A lot of our work beyond this spotlight on the relationship, the prevalence of medical billing and inaccurate billing among older adults is in our website. We have an entire page on medical debt. There you can find all the work that we're doing from policy to consumer education. And right now, we continue using the SIPP. We have a lot of interest in the medical debt of deceased of spouses and how that varies for certain surviving spouses and in certain states. And the SIPP provides the data to continue that work. I just want to thank all of you for joining today and the census for providing this opportunity for us to share our work. Here's where you can contact me and learn more about our office. Thank you.
Very much, Hector. All right, now on to our final presentation of today. This is work by Matthew Ray and Kritika Amin at KFF. So Matthew is the Associate Director of the Program on Healthcare Marketplace at KFF. The program researches and analyzes the private insurance market and policy proposals to reform it. In this capacity, Ray has managed the Employer Health Benefits Survey since 2011, and he has special interests in analytical methods and data analysis, including gleaning lessons from surveys and claims data. Prior to joining KFF, he worked at the Government Accountability Office, New York City Small Business Services, the Service Employees International Union, and the Oregon Federation of Nurses and Health Professionals. Ray is currently a PhD student at George Washington University's Milken Institute School of Public Health, and he earned a master's in public administration from the School of International and Public Affairs at Columbia, a master's of public health degree from the Mailman School of Public Health at Columbia, and a graduate certificate in survey design and data analysis from George Washington University. Kritika is an associate director of KFF's program on the ACA, conducting economic and policy research on the Affordable Care Act and its effect on private insurers and enrollees. Dr. Min is also an associate director of the Peterson KFF Health System Tracker Project. This project, a partnership with the Peterson Center on Healthcare, monitors the performance of the U.S. health system over time and in relation to other large high-income countries. Prior to joining KFF, she directed policy and research at the Center for Consumer Information and Insurance Oversight, the agency charged with implementing the ACA and healthcare.gov within the U.S. Department of Health and Human Services. Prior to this, she was a consultant at Vale Health. Dr. Amin has a bachelor's degree from the University of Pittsburgh and both a master's of science in public health and a PhD in health economics from the University of North Carolina at Chapel Hill. Take it away.
Thanks so much for having us, and thanks, Bryce, for that introduction. This panel is great because I feel like all three presentations are really talking to each other. I think what Cash really sets out like sort of assets that we can get, asset data we can get out of SIPP, and then both Hector's presentation as well as what me and Kritika are going to go over is about the medical debt variables and how that talks to the assets. So my name's Matt Ray, as said. Me and Kritika both work for KFF, which is an independent, nonprofit, nonpartisan organization. We strive to be an independent source of information on the healthcare system. We try to do analysis that are useful for understanding how the health system is working for everyday people. So KFF has experts working on all sorts of policy areas and all the ways in which people get health insurance. Kritika and I have a special interest on the unique challenges of those with private health insurance, although in this presentation, we are looking at Americans at large. So in particular at KFF, we focus on how is the health system working for people. So a lot of this work is done in our partnership with the Peterson KFF Health System Tracker, which is sort of an independent site we work with the Peterson Foundation on that does all sorts of data analysis around access, quality, and affordability. So a big chunk of what we're looking at is around medical debt in recent years. And that is because medical debt is becoming sort of an issue of the moment, and for good reason. So we're in this weird kind of moment in which over the last decade, we've seen sort of a real decrease in the uninsurance rate. So we're now up about 92% of Americans or so are covered by health insurance. At the same time, we've seen sort of heightened concerns over affordability of healthcare in some ways. So KFF does lots of public polling, as Hector called attention to. So we have lots of Americans tell us that they have real problems affording their health spending in for their day-to-day care. So about a quarter of Americans say that they had a problem affording healthcare in the last 12 months. I mean, there's good reasons for this, is that cost sharing can be really expensive, and lots of different ways in which people get hit with big medical bills that are hard for them to finance. I mean, just cost sharing for those with job-based plans, about a third of Americans now have a deductible for single coverage of more than $2,000, which is well in excess of the savings for a meaningful chunk of those with private health insurance. You know, you would hit with these big bills lots of the other ways in which Hector drew attention to, balanced billing, out-of-network billing, and all, et cetera, et cetera. So I think what Hector was talking about with the Consumer Financial Protection Bureau's complaint data is absolutely amazing to go through and read some of those. You really get a sense of the sort of impact of medical debt on individual people, which is what I'm trying to do now, is lay the motivation for why me and Kritika have spent time thinking about this problem. I mean, also at the same time, KFF has done a lot of journalistic work on this topic. So our colleague Noam Levy has done dozens and dozens and dozens of stories on medical debt that really kind of pull at the fabric of how this is affecting individuals' lives. So I'd be remiss if I didn't at least call attention to this. And you can see all that at KFF's website, or any of Noam's work is really worth checking out. But now we can get to the standard errors and away from the individual stories. So back into what we're seeing on medical debt. Again, why is this an issue that me and Kritika are thinking about? Is that medical debt is something that has sort of negative consequences on people's lives. Teasing out the effects are kind of complicated because people without a lot of money end up getting debt, but medical debt can also lead you to not have a lot of money. So there's a weird, there's a obvious kind of cyclical pattern here, and so it's hard to pull out the causal mechanisms in all these places. But I think it's almost obvious that medical debt compounds other forms of financial insecurity that people may be experiencing. So one of the things that we know about medical debt from our own polling at KFF is that people with medical debt are much less likely to use the healthcare system and to do the things we want them doing, which is using needed care, not skipping tests and treatment or follow-up care because of cost, and filling their prescriptions when prescribed and using their medication as prescribed, and not doing those things because they feel like they can't afford it. So we pretty clearly see from our polling that medical debt is associated with doing those behaviors. At the same time, we looked at this National Financial Capability Survey, which kind of looks at the financial picture of households, and we find people with medical debt just have behaviors that make it a lot harder to build assets over time. So this chart kind of looks at that. I mean, the two numbers on this chart that kind of jump out to me is if you have medical debt, you're more than twice as likely to be carrying a credit card balance, which is just a huge effect. And then you're 3 times as likely to be using a payday loan. So 44% of, did I get that right? No, I got the wrong number. 36% of American adults with medical debt end up using a payday loan over the course of a year. So these are, troublesome behaviors for building financial wealth. I'm going to pass it off to Kritika for the hard part of this presentation, which is what actually is medical debt and how do you measure it?
Yeah, so as you've been hearing, pollsters are finding that there's an issue that people are concerned about around medical debt. Journalists are finding there's a problem. Research like Hector's also shows that there's a medical debt problem. And so there's a lot of interest in pinning down exactly the extent of this problem and understanding how many people have medical debt and how much the medical debt amounts to in sum. And these things get pretty complicated pretty quickly. And Hector alluded to this, but one, you have to figure out what parameters you want to set in defining what to capture. So you can go from a narrower set, what is at the collectors, to a pretty broad set on what do people owe on credit cards, in payment plans, personal loans, payday loans, and so other aspects that affect people's financial stability. Like you heard, already, but just to kind of put a pin on it, the Consumer Financial Protection Bureau has taken a keen interest in this, and CFPB has looked at medical debt on credit reports and found that there's about $88 billion in medical debt on credit reports. They've also acknowledged, right, that medical debt reporting is much more fragmented than, say, retail or banking debt, and also that they've showed that if you look at just the medical debt on trade lines, which is like line items on reports, very little shows up there. And so credit reports are, of course, good because it's administrative data and we don't have issues that kind of come up in surveys like recall bias and that kind of thing. But survey data are also useful because we get more details. And so regarding how many people owe medical debt, several surveys range in what they ask respondents, and depending on what is asked, you kind of get different answers. And so I obviously don't need to explain to the survey creators and a lot of researchers here, but for the general audience, the survey of income and program participation specifically asks about outstanding bills that are not expected to be paid by insurance in the previous 12-month period. The most recent SIPP data is through December 2021 on this. The National Financial Capabilities Survey that's fielded by the FINRA Foundation, that survey is a point-in-time survey that asks people about their unpaid bills. So, how the question is said out loud to respondents is different. Our colleagues in the KFF polling team have a broader measurement. They've asked people about their own or their family members' healthcare debt. The KFF poll also prompted about dental bills specifically. Furthermore, our polling data is trying to get to a broader set of medical debt and healthcare debt. And so people were asked to report if they currently have bills that are unpaid on credit cards, on payment plans, loans, or stuff that's owed to family or friends. And this is all to say that these surveys get at slightly different things, and the way our people prompted results in slightly different results. And so what's under the hood in these surveys matters in what the estimates end up being, and what you count and who you count kind of thing. And so SIPP, in the SIPP survey, our analysis looked at it at the individual level, so share of adults, and that shows 8% of adults have medical debt. And if you look at that at the household level, 15% of households have medical debt according to SIPP. The FINRA survey shows 23%. KFF polling for just past due healthcare bills, it's similar to the FINRA Foundation estimate at about 24%. And then when you look at everything together, KFF polling found 4 in 10 Americans, or about 100 million people, say they have healthcare debt, according to a broader definition, which includes healthcare debt on credit cards, owed to family members, dental, that kind of thing. Yeah, and so why we think SIPP is great. Like I won't call Matt a nerd, but as data nerds, we get all these other details on people and people in their households, and not just the person. There are also geographic details that we were able to use. We had to pool some years together to get a sampling that we felt comfortable with, but still pretty cool. SIPP is also the only survey we know of that also asks people about the amount of medical debt that they have. Of course, there's credit reports data like Hector was talking about, but SIPP might be capturing other stuff that might be mixed in, for example, credit card debt, payment plans. Some considerations to mention here, the medical debt questions in SIPP were asked of people ages 15 and older in the household. Whereas some other questions on debt, like on credit card debt, SIPP asks all ages in the household. We also made considerations on what to do with extremely high amounts of medical debt. These amounts can influence the total by a lot. Just to give an example, 0.3% of it accounts for like half of the total debt. And so we took a more conservative approach there, but let me pass it back to Matthew and he can share some data from our nerding out with this data.
Thank you, Kritika. I should mention as well, because Hector mentioned in his previous presentation, the Federal Reserve runs a survey as well, which also asks about medical debt, the SHED survey, which asks about the household and the person combined. So that's another, a fourth estimate, I guess. So, I mean, this is the findings part of our presentation. So what do? We looked at the prevalence of people who have at least $250 in medical debt. We kind of picked that as an arbitrary number because it's something that's consequential. There's a big chunk of people in SIPP who have nominal amounts of money reported as debt or a $0 value. And there's reasons, there could be reasons for that based upon what the reference to both questions are. And in this, we're using the same questions that Hector and CFP used in their analysis. So what we find, there's about 2 million people or so who have less than $250 in medical debt. What we're finding is 8% of people have got more than $250 of medical debt, which is, in my mind, a huge number of people. So there's lots more analysis by various groups in our work on the Peterson Health System Tracker, as well as work that the Census Bureau has done looking at various health utilization measures and medical debt. So I mean, two things that jump out to me right off the bat is one is that medical debt kind of increases with age, which makes sense because the thing that drives medical debt is using the healthcare system. And the older you get, the more likely you are to have health spending and the more likely you are to develop chronic conditions, which require the repeated visits to hospitals or physicians, which can lead to debt. Now, there's this big fall off when you hit 65. So that group above 65 has got a totally different profile. And I mean, we just learned all about that, so I'll skip right past that. But for the group that is kind of interesting for those of us who are interested in employer-sponsored health insurance, we're looking at between 11 and 10% of middle-aged people are having medical debt. Now, the second kind of chunk of bars here, the light blue color, is looking at insurance. So we think of insurance as being, we have health insurance to be protective of our assets when we have a medical emergency or we have ongoing health spending. And for 8% of those people with health insurance, they still have medical debt, which is kind of a finding that gets at how underinsurance may be a problem for some populations. I mean, a third finding that's not listed here is about race. And we saw a great breakdown of assets and wealth and inequality in the first presentation by Rakesh and the work from the folks at Pew. I mean, we find the same thing here. So non-Hispanic Blacks are about twice as likely to have medical debt as non-Hispanic whites. And obviously, for all the reasons people have said all day, there's so much information on households. You can break out those effects in lots of ways. Unfortunately for America, but great for statistical analysis, there's a huge number of people with medical debt, so there's lots of sample here to work with. So this slide kind of gets at two things. The two big drivers of medical debt is using a lot of medical care and two, having a low income. And those two things kind of work together. So as invariably people who are both low income and have worse health status end up with a lot more medical debt. So nearly of those who report having poor health and an income below 400% of federal poverty reported having medical debt. And no matter what your income is, you're more likely to have medical debt if you are in worse health. As I said earlier, the Census Bureau did a ton of analysis on this, looking at how medical debt changes with having a disability or having various healthcare utilization measures, which all kind of echoes the same finding. Next slide. So like so many things in our health system, geographic variation really matters here. So we pooled a couple of years of SIPP data so we could get state level estimates. I think this is 3 years, right? Is that what we ended up doing? So what we find is that Hawaii and DC have relatively low levels of medical debt, but then in places like South Dakota and Mississippi and North Carolina, we're reporting almost 1 in 5 people in South Dakota report having medical debt. I mean, this variation is driven by a whole bunch of things, including patterns in wealth, health, and policy. Obviously states that have not yet expanded Medicaid to the eligible population under the Affordable Care Act have a higher level. That's not necessarily causal, but I mean, there's definitely a pattern there. So this gets to the real challenge. The next question is, how much debt do people have? And this is the tricky bit. So as I said before, there are 4 surveys at least, and more for the Medicare population, that look at not just how many people have debt, but how much is that actual debt. And it's a little tricky to tease out the effects. So most of the 20 million adults who have medical debt owe more than $1,000. And about 11 million people owe more than $2,000. So, I mean, I would say 11 million people are carrying around a significant amount of medical debt. Now, it's a little uncertain on doing the average here or calculating the total debt in aggregate because the distribution is so heavily skewed. So a small number of people have a lot of debt, and it makes it really hard to get a precise estimate from a survey statistics perspective here. So what we did is we summed up the total amount of debt between $250 and a cap of $225,000, which is what the top coded value was in SIPP in the year we were looking. If you don't do that, and even if you do that, the total amount of debt fluctuates from year to year in ways that it's probably more to do with uncertainty in the survey than it is to do with massive changes of held liability. But I mean, either way, the story's pretty clear here from my perspective. The first thing to take away from this is that even in this conservative way of doing this, the way we did it, there's a lot more debt out there than you get just by summing up the value in credit reports. So to echo what Kritika said earlier, there's $88 billion of medical debt on credit reports. And we're getting about $220 billion from people that have between $250,000 and $225,000 in medical debt. I mean, the second thing is that one more point, and I'll pass it off for the tough part, is that we have a lot of people, the vast majority of this debt is being held by people who have big values of debt. So more than $10,000 is 78% of the debt. Kritika, you want to take us home here?
Yeah, so Hector mentioned this. There is, of course, a lot of interest at CFPB, and the CFPB has taken on regulatory action to restrict medical debt reporting and debt collection practices. Various government, private sector actions are also aimed at reducing medical debt. So, for example, with medical debt that shows up on people's credit reports, the credit reporting agencies have removed stuff from the credit report. So medical debt already paid or stuff under $500 should no longer be on credit reports. And these are 3 of the largest credit reporting agencies: Equifax, Experian, TransUnion. And so nothing to sneeze at here. Like something's being done. I guess states have also made efforts to reduce the burden of medical debt. So, for example, Arizona capped the interest rate for medical debt. Maryland has passed restrictions on hospitals and what hospitals can do in terms of medical debt collection practices, particularly from low-income patients. Some other states have passed measures to prevent all amounts of medical debt from appearing on credit reports. And then there's also, local governments, state governments, local community groups that have been trying to buy out low and middle income residents' medical debt, at the price of like pennies to the dollar kind of thing. And these efforts help consumers. Of course, they don't change the root cause of medical debt. that's high healthcare costs and underinsurance. At the same time, for people with medical debt, having their credit freed up or getting some of their debt paid off can be a big deal. These are folks who are more likely to say they're living paycheck to paycheck, taking payday loans and with very small or no financial safety nets. So medical debt can really affect their living costs for housing or cars to get to work. And with that, we just wanted to say thanks to the Census Bureau folks for working on this survey. As Matthew knows acutely from surveying employers, it's a tough job, but these surveys provide important information, and we're huge fans.
Thank you. So we've got some time now for questions. And so just to, I guess I will get us started. All three of these presentations did a really nice job of highlighting some really unique questions that can really largely only be answered using the SIPP. And so for each of you, in thinking about what the types of work that you would like to do in this area going forward, what would you most like to be able to get out of SIPP? So as we're thinking about how we can continue to improve the survey, what types of things would you like to be able to accomplish with the data that we would like to be able to make available?
I guess Matt and I can go first since we just stopped talking. But we obviously have a list of things that would be like nice to have. And I'm sure we've pestered you a couple of times. The panel nature of it is really nice. We're interested in kind of understanding, like as some of these regulatory and other actions happen, sort of like how that affects people who did have medical debt going forward. Yeah.
I mean, I get, obviously, on the topic of medical debt, I mean, so I'm interested to know what Hector thinks as well. But so for us, the question that's really unique or useful is the distribution question over how much debt people are holding. And that raises a bunch of questions with the variable that's there. So one is the people who will hold no debt in the year. So they say they have medical debt and then they report a value of 0. I think that's because the question is, end of this period, did you have any debt? And then you say, what's the debt at this moment? So it would be nice to know a little bit more about these people reporting 0 debt, but that they have debt or had debt. And maybe something about so it's always hard to ask for new questions because you guys are stuck having to ask about income and program participation. So you got enough questions already. But it'd be great to know how long people have held debt, trying to get a sense of how much of a burden this is in lives. Also thinking about this question about how much debt people have, like the top end just goes on to outer space with the top debt holders holding astronomical sums of money. It would be great to probe a little bit on that subpopulation to figure out how they acquired so much debt and verify that they're not thinking of their mortgage as medical debt or something like that, which may be the case, that they may have taken a lien on their home or something. But with so much money being held there, to get a sense that the average debt level, which is what I think from what CFPB was reporting and what we want to report as well, that mean is really driven by a very small number of observations. If I can keep talking, I mean, the other thing is there's a bunch of things that are really significant on how you answer the debt question. Like the one is if you count dental insurance as part of medical debt, I think that really counts to whether you say yes or no to that question. So if you can think about that in some way, I mean, I hate to ask you to add another question. I don't know if Hector, with your cognitive testing, if you found that. The other thing is whether people think of the debt when they respond to the debt question, if they're responding on the household or for themselves. So I know as a respondent, I would absolutely think of my toddler's self-spending as my debt, but I may not in other cases. So separating that effect, I think, is one of the household versus person thing is one of the things that really varies in how the questions are asked across surveys. So that was like a whole bunch of stuff, but also I'll be quiet and let others react to that.
Yeah, I want to say that, they highlight Matthew the core need for some of these topics to go back to some basics of cognitive testing and how people think about and what they include and exclude. It was helpful for us to go through that exercise. One, because we we were interested in inaccurate billing, and that may not necessarily be captured fully in a question like the SIPP. We were also interested in particular things like some types of medical durable equipment. So we're happy to sort of continue that conversation. But credit card was another one that a lot of people, when they looked at your survey question, they did not think that it belonged in that category if they paid their bill. But that being said, that's the key to all of this is that your survey data will become increasingly more important. The credit bureaus, as they remove some of these out of the smaller amounts, what we are relying now as our source to understand any type of unpaid bills is survey data, and survey data that is comprehensive and well collected. And so again, this is the value of this, to track these trends over time. I also want to say, when you said the important things, we look a lot of these patterns from the lens of risk and events that happen in people's lives, and that's true not just for the presence of debt, but also for the accumulation of an asset, of any kind of asset. Like, did you sell your home? Did you deplete your bank account, which may be more common among the older segment. And so measures that capture the certain shocks in the household are important to us, from the experience of natural disasters to the experience of court-related order, like things like a battery of questions trying to capture common or highly expensive events in people's lives that could again explain depletion of assets or a wide range of debts that you collect in your survey.
Just to add one more thing, the Kansas City folks were also talking about this, but the idea of what Hector also mentioned, just ins and outs and how families and households think about assets and debt is kind of at a financial household unit. And so, in our analysis, we're looking at share of adults, but then for income and things like that, we're going to look at the household income. And so I think it's important.
Real quick, I will specify, or I think it's important to note that in in our future panels or versions of the SIPP, we have added questions to identify whether assets are individually or jointly owned for the household. So that should help, at least with some of the identifying what's happening within the household versus at the individual level and how people respond to that. Rakesh and Mohammed, yeah, thoughts on that?
Well, I'll speak from the perspective of wealth. Just my quick take, not a considered take. So I think we too struggled a bit with the debt variables. We would have liked to have gone deeper into the types of debt and how they varied across racial and ethnic groups. But we quickly ran into very high standard errors on some variables, and especially compounded by the fact that sample sizes are, even in SIPP, relatively small for outside of Hispanics and Blacks. It's difficult to say anything else about other groups. So we were not able to report anything on, or very limited amounts on multiracial groups and some of the smaller racial ethnic groups. So more, I guess. I mean, I think from the wealth perspective, the greatest benefit or advantage of SIP is that you're giving us an annual take on household wealth, assets, and debt, which the SCF is not able to do, and it's a very valuable commodity. I don't know if Mohammed has any additional thoughts.
My thoughts really pertain to my experience as a first-time user. Like Rakesh said, we had really positive experiences reaching out to the team at SIP when it came to questions like how do we identify like households individually? How do we identify the household head? How do we maybe replicate some of the findings that are in published tables to make sure that we're following the right methods and using the right code? One suggestion I have along those lines, maybe to help with the learning curve, is to publish some of the code that produces the published tables, just so that as people move through the process, if they want to expand on the research in any way, they're able to know that they're going in the right direction and that they can at least match the methods used by the SIP team when they generate their published tables. There's already some of this in the manual, at least when it comes to like setting survey weights and figuring out which using survey weights and figuring out which groups to like how to identify groups, but I figured maybe publishing some more code might be helpful.
I want to sort of follow on that one, and I want to thank Matthew's team because they precisely it was our community of practice. They share some of that basic code, and we were able to sort of build upon that. And it's something, for instance, that the HRS does, where they post all their papers that have been written, and that way sort of helps people like me like knowing who to ask for, can you share the code? And so again, a community developing some level of community of practice to will be supportive of the use and facilitate a lot of this work.
And that is one of the driving factors behind the SIP conference, which started last year. It's to bring together people who use this, from our bias perspective, really unique and valuable data set that doesn't always get as much attention as the more popular like CPS and things like that. So thank you all for your comments on that. One thing that, as you are, as you most alluded to, like trying to get better ideas about being able to dig into like components of assets or debt. One issue that we face is, and this is across surveys, whether it's at Census or ELS or HRS at Michigan, is decreasing response rates. And so one of the things that we have played around with is 4 variables that are potentially harder for people to answer, such as questions about assets and debt. Would a modeled be able to replicate that in our survey data? So if we were to put out, say, a modeled version of medical debt or something like that, do you think it would be as useful? Or what do you see as the I guess pros versus cons of that type of thing being put forward?
Yeah, well, I'll go for Matt.
Oh, sorry. I was just saying, like, in my mind, the challenge with doing a synthetic sort of thing is that when you get to subpopulations, which the parameters aren't considered in the model, you just don't feel as good about your reporting. So the sort of stuff that Hector was reporting there with, like, not just the overall medical debt, but the medical debt by subpopulations of dual insurance categories. It just gets really hard to believe you're going to model that stuff in a way that you feel good about. But I mean, we're facing real challenges here, so my hat's off to you guys on trying to keep this thing together.
I guess talking of modeling, imputation is a form of modeling, and first thing researchers tend to do is throw out the imputed variables or people who have imputed income and things like that. So yes, as a researcher, you wonder, are you introducing more error by using modeled estimates or imputed estimates than you care to have? But let me ask you a question. Now, you are not engaged in, say, public opinion survey work, obviously, but is there any hope for web-based survey work that makes up for some of these gaps you're facing?
What do you mean by web-based survey work? Like,
Well, say, for example, at the Pew Research Center, we have moved almost entirely to a web-based panel. Rather than no telephone calls, and people are approached only through the internet, and they respond in that fashion. It involves a lot of background work on it's a different mode. What did that mean for outcomes, data you collected, and so on. But that's where we are. Polling work has all gone onto the web.
that is actually a perfect segue a bit into what Neil, who just popped on the screen, is going to be talking about in the next session.
Okay.
So I'll let Neil answer that.
Yeah. So, I mean, as Bryce alluded to, in the next session, I'll go over, the new SIP design and our plans for, modernizing the survey. But I'll go a little more into detail on this later, but just as a quick answer now, we are working on developing a multi-mode design for collecting. So moving towards like a web push design where we have respondents, have the opportunity to respond online or an internet self-response first, and then we would follow up with in-person interviews. So absolutely something that's on our mind right now.
I want to sort of also, I'm thinking the other data set that I work a lot with is the health and retirement study. And on one thing that they do that may, that could be promising, particularly for the SIP, are their experimental modules, where they fielded to just a small, like I think it's a tenth, they do 10 and it goes to a tenth of their sample. And that's how they have covered a very wide range of topics, and have also sort of been a way to get a lot of economists and researchers to get engaged with that data. And so just an idea of once in a while, like sort of adding a few, like, and these are very small. We're talking about I believe is 5-minute type of things, or less, or a couple of questions. And so just one thought to in the future, as you're considering, again, ways to include new topics without committing your full resources.
Yeah, I mean, it's all a balancing act, and we've been, for years dealing with how to better impute variables, because we already will miss a good portion of the sample when answering questions. And so, you mentioned one of the first things that you do when you start a project and you're looking at the data in the survey is drop imputed responses. Well, in the SIP, and it's becoming more common in our other surveys here at Census, for variables like earnings, we are incorporating a lot more administrative data in how we impute. So those model-based imputations probably are actually closer to what an answer would be than not. And so that is one of the ways that we're trying to overcome that problem. And there's laundry list of things down the road that we hope to continue to try to better improve the survey and pick up things in a way that doesn't overburden people who are taking the time to answer the very long survey, while also collecting this rich information so that we can make it available to you guys. Because that ultimately is the end goal of what we're doing here, is to make data available that can be used by practitioners to inform public policy and just a better understanding of our U.S. populace. Right. Are there any other questions? I don't see any in the Q&A, so I think we can end a little bit early. I'll hand it over to Jason here to.
No, that's and I really enjoyed this session, and you're getting it like the meat of what's in SIPP, how it can be used, how it can be helpful, and hopefully we'll be able to bring it all together as well in the new version as we think about what should be in it. You're making good, strong arguments for a lot of the content that's already in there, which our data users always do, because everybody has their piece and they really have very strong reasons for why they like it. We're going to go ahead and take a break now.